Hello and welcome to a brief webinar on Section K of the MDS, Swallowing and Nutritional Status. The following will present some ideas for support for documentation of this section of the MDS. Our objectives are going to be for participants to understand the components of Section K, as well as the scoring criteria for select areas of this section, and to understand how Section K is going to impact reimbursement under PDPM. So it's important now because Section K indicates the presence or absence of a swallowing disorder and an altered nutritional approach. It includes the presence of feeding tubes and altered diets and looks at relevant swallowing disorders and diet alterations because those areas are going to impact patient classification under PDPM and can drive the payment component of speech-language pathology. The beginning section, K100, Swallowing Disorders, considers swallowing difficulties within the past 7 days, even if the symptom only occurred once. And those symptoms might include a loss of liquids or solids from the mouth, holding or pocketing of foods, choking or coughing during meals, or even medication pass, and complaints of pain or difficulty with swallowing. Section K100, speech therapists are trained to look for subtle indicators of swallowing issues, such as pocketing small amounts of food or inadequate bolus cohesion. That might be when you see that scattered residue about the tongue after a person has swallowed. Speech therapists screen new admissions for swallowing issues and can observe some specific concerns that might impact the MDS. Section K100 also assesses unsuccessful diet interventions to determine the need for further treatment. Maybe something that was attempted in the hospital needs further refinement, and Section K100 will capture that. Speech therapists can also help this section of the MDS to determine problems by observing the person in the morning versus the afternoon. They can look at the person in various positions, how they do with swallowing while they're perhaps having breakfast in bed versus how they look when they're swallowing their lunch seated upright in a wheelchair. They look at the person before or after some significant medications that can impact perhaps their level of alertness or their coordination. And speech therapists also will look at dental issues such as loose-fitting dentures, mouth sores, and other issues that can impact the effectiveness of swallowing. So aspiration. Speech therapists are specifically trained to observe residents for signs or symptoms of aspiration. And in addition to what's noted in Section K100, signs or symptoms of aspiration can include a gurgling or wet-sounding voice, either during or immediately after eating or drinking. It can include difficulty coordinating breathing and swallowing. And sometimes we see that with our COPD residents. And it can include foods or liquids leaking from the nasal cavity. Speech therapists are also specifically trained to assess for something called silent aspiration, and that is the lack of obvious signs of food or liquid entering the lungs. So the person won't cough or choke, and yet the food may still be going down the wrong way and ending up in the lungs, resulting in a pneumonia. Again, speech therapists are trained to look for the silent aspiration, and if they find that the individual may have that, then obviously speech therapy would be indicated and possibly a modified diet to keep the person as safe as possible. From the American Association of Nurse Assessment Coordinators, they have a Q&A section, and one of the questions was, with Section K, if a resident is on thickened liquids and speech is trialing thin liquids and the resident coughs, does that trial with coughing count to code coughing on Section K100C? And the question further goes on to say, also, if a cued cough is being used as a strategy to help prevent aspiration, does that count as coughing in Section K100C? And the response from Carol Mayer with ANAC is that the instructions in the RAI manual state to code if it happens one time during the lookback. Coughing during a trial of thin liquids should be coded in Section K100. However, she would not code a coughing as an intervention. So if coughing is used to prevent aspiration, it would not be coded. If it occurs during a trial, it would be coded. Sections K200 through K310 looks at height and weight. The RAI manual describes very specific time frames for weights and the rounding of numbers. It strongly recommends consistency with weight taking, including with the shoes on or off, morning versus afternoon, making sure you know the weight of the wheelchair if the person is to be weighed while seated in a wheelchair. The weight must be from the past 30 days, and calculations for weight loss or gain in the past 30 and 180 days are defined and described in the RAI manual. Very important is that documentation needs to support deliberate weight changes, such as diuretics for edema resulting in weight loss, or perhaps weight gain if the person is on supplements. Make sure your documentation supports those changes. Section K510, looking at nutritional approaches, determines interventions, if applicable, while not a resident and while a resident in the past 7 days. Looking at parenteral and IV feedings, feeding tubes, looking at mechanically altered diets, such as the change in textures of the food or liquids the person's consuming. Again, that can impact speech therapy significantly, especially under PDPM. And Section 510 looks at therapeutic diets, such as diets that are low in salt or diabetic diets, those types of modifications. Speech therapists will carefully review the chart, including any previous speech therapist notes, to determine if the history of diet alterations has been happening. And it's important to consider all nutritional approaches provided in the 7-day look-back period, both before and after admission, for inclusion on the MDS. So make sure we know of those alterations within the past 7 days. Under Section K510, what may be coded? Parenteral and IV feedings may include the below fluids if documentation supports their necessity, which would include IV fluids to keep a vein open or IV fluids contained in the IV piggybacks, certainly prevention of dehydration. And then there's some additional fluids noted in the RAI manual that tend to be a little bit more few and far between for most of our facilities. Section K510, what may not be coded, includes IV medications, IV fluid flushes, IVs to dilute medications, including those that might be a part of chemotherapy or dialysis. Enteral feeding formulas are also not a mechanically altered diet, according to the RAI. So with supplements, they are not a therapeutic diet by themselves. They may be a part of the therapeutic diet if provided as a part of a therapeutic diet to manage a specific condition, such as a protein-calorie malnutrition. And interestingly enough, food elimination diets related to food allergies can be coded as a therapeutic diet. Section K710, a percentage of intake by artificial route. The RAI manual specifies timeframes of while not a resident, while a resident, and during the entire past 7 days. It considers proportions of total calories received via parenteral or tube feedings. It looks at the fluid intake by IV or tube feedings. And there's some very specific calculations for the percentage of intake noted in the RAI manual with some good illustrations and examples as well, so that we're doing appropriate calculations. Some final thoughts. A careful chart review is going to be critical by the entire interdisciplinary team, especially as we move towards PDPM. We want to make sure that we capture all of the relevant information that can impact case mix scoring under PDPM. Communication and documentation of chart findings is also going to be essential to support Section K if we find a person has a history of dysphagia or modified diets. And we need to be careful to look for any other speech therapy-related comorbidities as we scour the charts for relevant information. So I thank you for your attention to this brief webinar, and I wish you well as we move towards the PDPM model in the days ahead.